Good afternoon, everybody. Welcome to this industry-sponsored symposium on biologically clearing the barriers to wound healing and how we change the wound healing environment through debridement. So I'm Ira Herman, and together with my esteemed colleagues Jeff Lehrman, Chandan Sen, and Dot Weir, we will take you through this program. Here are our disclosures as we're obligated to share with you. And of course, we have three major learning objectives for this session today. We want to assess recent data that we want to assess how recent data on bioactive peptides might change the wound healing environment and the role that collagenase is actually playing as a debriding entity. And then, of course, with respect to how bacterial collagenase and xanthol may also be doing other important things, including debriding the wound, we'll cover how debridement may modulate the inflammatory and infective status of the chronic wound. And then what will all this mean to us as practitioners and as innovators? How will we translate this data on debridement to the spectrum and continuum of care across the wound healing community? So let me quickly share with you some updates from our group and Center on Innovations in Wound Healing in Boston at Tufts University School of Medicine. Of course, we all of us want to live forever, and we want to have a healthy and meaningful life. We aim to either, if in fact things go wrong, repair what's broken. If in fact we can't repair, we want to perhaps restore or regenerate the functionality. And if all of that doesn't go well, then those of us who are doing innovations in vitro organ assembly and engineering organs outside of the body, we aim to perhaps someday be able to replace our organ systems as needed. So with repair in mind, we appreciate, and especially with respect to the enzymes that regulate the healing responses, like the metalloproteinases, in particular collagenase, we appreciate that normal repair is in fact in equilibrium between synthesis and degradation, and that proteases are in equilibrium with their inhibitors, and that this sets up a whole sequelae of events that begin as the stopping of the bleeding, as platelets are involved, through the modulation of the immune response and the adaptive immune machinery that's embedded in the cells and the molecules that are released as cytokines, and through the immigration of these inflammatory mediators and the migratory and proliferative responses that follow the matrix and the cells and tissues that make up the organ system in particular, that all this takes place and is remodeled in a way that involves many, many cells, as everyone in the room appreciates. With respect to chronic wounds, that may not necessarily be the case, where in fact the proteases and their inhibitors may be disequilibrated. And so I've dubbed this situation where chronically inflamed wounds are trapped in a non-healing status a conundrum. And it may be as a result of elevated metalloproteinases that destroy, for example, cannibalized growth factors or their receptors. It may be linked to the infection status of the wound, as all of you practitioners know, and that this bioburden can, in fact, alter, as we said, the immune system in ways that alter the inflammatory mediators. And, of course, all of this is being driven in the dermal compartment by the remodeling of the vasculature that's so instrumental and critical to the healing process. So with respect to either infection and immunity, with respect to issues in offloading, with respect to perfusion and control, or the ways in which we live our lives, whether we eat cannolis or we don't eat cannolis for dessert, we can, in fact, influence the rate and extent of healing. And, of course, and especially important for non-healing wounds, the contribution of necrotic tissue and the absolute need to remove the necrotic tissue by one or another means to foster what might be a healing environment and a wound bed that might be, in fact, prone to healing rather than being stalled in a non-healing status. So with respect to necrosis and necrotic tissue and debridement in particular, there, as again all of you appreciate, many opportunities for those in clinics. If, for example, you're a surgeon, you like steel, and will probably want to remove the necrotic tissue by mechanical debridement and surgical debridement. The body's own responses are able to do this on its own, their own, and of course, autolytic debridement. And then, of course, there are things that probably go beyond lunchtime conversation in the biosurgical category for debridement. But with respect to this particular symposium and our desire to want to be able to deal with necrotic tissue, we're talking about enzymatic debridement and, of course, Clostridial collagenase, which is awesome in its ability to actually degrade the necrotic tissue by acting on denatured collagen. However, there are opportunities and advances that we've come to appreciate, and work in our group has really been focused on the important role that remodeling matrix plays in stimulating the responses to injury and healing in particular. And especially important with respect to Clostridial collagenase, the enzyme in SANL, the enzyme actually degrades collagens in a way that's uniquely different, similar but different than our own host mammalian enzymatic machinery. So in the case of our own human metalloproteinases, you see that there's an iterative process where, in fact, you make breaks in the collagen chains and then other proteases are involved in making peptides, whereas, in fact, the Clostridial collagenase is able to make small peptides by its actions on a collagen backbone. So we put this to test. We asked whether, to what extent, if we added a bacterial enzyme to matrix upon which cells would be growing, in this particular case, human keratinocytes, whether to what extent we could stimulate proliferation. In fact, as we saw, as we published, we can greater than double the rate of proliferation of human keratinocytes when those cells are placed on matrix that have been treated previously with the bacterial collagenase. And that if we had low concentrations of the bacterial enzyme chronically present in the media which the cells were growing in fact, we could double again. So greater than fourfold increase in growth rates as a result of manipulating matrix and growth conditions using this enzyme. In fact, we then went on to test and show, and were able to demonstrate that the enzyme indeed might be an active healer. As you can see, all of the wounds in this gallery of representative images at the same time point compared to untreated and covered controls, or PDGF-treated but Capillary-treated controls, or untreated and covered wounds, all of the collagenase-treated wounds were healed. And we published this a decade or so ago, and we reasoned that perhaps the mechanism by which the enzyme was promoting healing, in addition to its ability to do debridement, mightn't be linked to its ability to cleave growth factors from sites in the matrix. It might have been responsible, perhaps, to activate or switch key receptors that were transducing signals needed to promote healing, or that, in fact, it might be responsible for cleaving collagens and collagen-associated proteins to peptides that might be able to promote growth, mitogenic, promote migration, motogenic, or promote the changes in shape that are necessary in order to do vascular remodeling in the dermal compartment, morphogenic. And so we went on to test this, and here in this cartoon that we published a few years ago, you can see the central role that metalloproteinases may be playing in actually promoting healing by producing these bioactive matrix fragments. And so to test this specific hypothesis that collagenase digests the matrix to produce these bioactive peptides, we've set up a whole series of preclinical in vitro and in vivo testings to both validate directly whether indeed the enzyme is able to produce peptides, and then if in fact this is true, what are the peptides, can we chemically synthesize and then put these peptides back on test and ask whether to what extent they can promote keratinocyte migration, proliferation, promote granulation tissue formation, or promote angiogenesis in response to injury. And so here, for example, is a list of some of the peptides that we've discovered, the binding domains that they possess, and the important role that they may be playing. We've gone ahead after characterization of these peptides and synthesized them. And in addition to the collagen-associated peptides, there are indeed collagen-specific peptides that we've now put on test in some of our high-throughput and medium-throughput screening assays in the laboratory in Boston. And so, for example, in this particular assay, you see endothelial cells, which make up the inner lining of all the vessels of your body and the chambers of your heart. And you can see under control conditions, this population of endothelial cells derived from human dermis and from capillaries from human dermis is not able to form the linkages and grow and form the capillary-like structures that we call angiogenesis, the budding of existing vessels from preformed vessels. One of these peptides is sort of okay in doing this, and another one of these peptides really good at doing this. And you can see as we characterize the rate and extent of these peptides derived from bacterial enzyme cleavage of an existing matrix, that these peptides, to a greater or lesser extent, can promote the morphogenesis, the angiogenesis that's needed for healing in vitro. We've also been able to demonstrate recently that, in fact, these peptides are able to, one degree or another, stimulate the growth of these blood-lining capillary endothelial cells, even more so than what are known to be the key angiogenic activators, which are essentially the gold standards in the field. In this particular case, you can see that peptide number 6 is actually better at promoting endothelial proliferation than basic fibroblast growth factor, FGF2. So with this data, we were excited, obviously, and wanted to turn to some impaired models of injury and repair using some of the animal models that are available to us in the community, both in small animals as well as in large animals. I just wanted to quickly share using cyclophosphamide to make these animals neutropenic so that they actually have delayed characteristics of healing. You can see, and I apologize for this not so appetizing image of this mouse with a full thickness excisional wound over its cranium. We do this over the cranium because, as some of you may know, on the flanks in rodents, much of the healing is contraction-based. This is not the case over the cranium, where it's much like the human responses to injury, where migration and proliferation drive healing responses. So here are some representative images from histology from these wounds which we created over the cranium in mice after being treated with cyclophosphamide to make them neutropenic and impaired for healing. Under control conditions, of course, all these wounds are covered in standard practice. You can see that the epithelial tongues in the control wounds are nowhere near touching one another, that this fibrin scar and the wound status is completely open. This is in stark contradistinction to peptide number 6, which actually has a fully restored epithelium. And if, in fact, had shown at higher power, you would be able to see the robust regranulation and the granulation tissue giving rise to a remodeled vascular bed. This fully repaired wound is quite similar to actually the wounds that have been treated with the enzyme, bacterial enzyme, Clostridial collagenase that you have in Santal. So again, quantitation shows us that statistical significance is achieved with some of these peptides and not others, and that the enzyme itself, collagenase itself, published over a decade ago, that the enzyme itself, in addition to its ability to do debridement, actually is an active healer. It promotes healing under these controlled conditions in animals and in vitro. So to sum, and before I turn the podium to Professor Sen, the peptides that we've now discovered, characterized, and synthesized chemically capture all of the activity embodied in the enzyme and go well beyond that, we believe, in their ability to both promote vessel growth, remodel granulation tissue, as well as stimulate the migratory and proliferative responses to injury, as is so necessary, embodied by the epithelial cells, the keratinocytes. So for those of you at cocktail parties later, you can share that, in fact, we have been able to demonstrate that matrices produced by keratinocytes, fibroblasts, and endothelial cells all give rise to collagenous and non-collagenous components that can be attacked by the Clostridial enzyme, collagenase, and that those products of digestion are informational in and of themselves, even beyond what their parent molecules were able to talk about in the context of cellular space. And that the concentrations are in the nanomolar range, and we believe that these preclinical data in fact give us opportunity and insight into what might be the next generation therapeutics that could come from this enzyme, which currently has such value and meaning in clinics with respect to its role as an enzymatic debrider. So I'd like to turn the podium, as I mentioned, to Chandan Sen from Ohio State University, who will continue the discussion.
Thank you, Ira. Yes. That makes for a perfect segue into my talk, where I would really continue the same story pretty much along the lines of what happens to wound inflammation as we debride wounds with enzyme, and in this case also I'll share with you Clostridium collagenase story. Now, before I get there, and as of now what we have from the literature, it is estimated that about 2/3 or one, or so of all wounds suffer from biofilm infection. Now, very briefly, what is biofilm? So this is a form of infection where the same bacteria, when I say the same, I mean not in the biofilm format, but now they are establishing communication among themselves, something broadly known as quorum sensing, And in addition to that, they end up making this extracellular polymeric substance, indicated here as EPS, in which these bacteria get encased. Now, the interbacterial or intermicrobial talk, as well as this physical structure, taken together, makes them recalcitrant to antimicrobials, and also they have a way of sedating, if you will, the host immune defense system. Now, there is a general understanding that, well, if you have biofilm infection on the surface of a wound, you debride and you got it. So what's so complex about it? Now there are more and more studies coming out, and essentially, and this is one shown here in the Journal of Pathology that came out a couple of years ago from our laboratory, and there are other such studies that show that indeed when you debride by any number of mechanisms, you debulk the biofilm, so 90+% of the biofilm is gone. But as you see here, in this case of a polymicrobial biofilm, in a wound you don't expect a single microbe, so you have a polymicrobial biofilm, so you have here Pseudomonas in green, Acinetobacter in this particular case in red, and anything you see in yellow is co-localization of these microbes. And what you see here is you have much on the surface, but then you also have in some of the deeper tissues. The point I'm about to make is that in general, debridement will debulk biofilm infection. However, in some of these fragments that are perhaps beyond the reach, so when we debride, we really don't have any way of visualizing what exactly we are doing. So it ends up such that there is a high possibility that some of these biofilm elements get actually pushed deeper into the tissue during debridement. And this is being seen, and the next day, that same day, it's all clean. A week later, 2 weeks later, it all comes back. And those of you nodding the head in the audience, would have seen that during clinical practice. It all looked very clean and bloody and red, but they all came back. What happened? So this is something to keep in mind as we debride. So debridement does part of the work, does not do all of it. Now that's another story. So now to come back to this general diagram where you have debridement, where you are trying to get rid of biofilm, and then you have this yellow arm that talks about how debridement could directly help resolve wound inflammation. And I'm going to be mostly focusing on this arm during the subsequent part of my presentation. And as you debulk the biofilm or get rid of the biofilm, you also then push the inflammatory status to a more resolving state than a chronic inflammatory state, because persistent infection caused by this persistent bacteria in the biofilm format enrage the immune system, and you have this persistent inflammation going on. So on one hand, biofilm has many types of threat it poses, but one of which is that it would keep the inflammatory cells sort of enraged for a longer time, and you would have this chronic inflammation set in. That said, when we are talking about collagenase or enzymatic debridement in general, one of the key targets, as you just heard from Professor Herman's talk, is that collagen gets broken down. Now, there are a number of ways of breaking down collagen, and I will not have the time or the scope to really address that here. But the point is that you have, as you use this collagen, and as you think you are getting rid of a lot of collagen mass, a lot of dead cells, in the meanwhile, what happens is you also end up with a number of collagen fragments that are now in the wound, which otherwise would not be. Now, there's a very interesting angle to this, and you heard about peptide 1, 2, 3, 4, 5, 6 in his case. Now, of course, his peptide fragments and the one we study are not exactly the same, but I would not be surprised if some of them overlapped. But in this case, the interesting part is we cannot forget about the peptide fragment because of a number of very good reasons. What are they? First of all, macrophages, and in this case you heard about keratinocyte and all the cell types. I'm going to focus on macrophages. As you know, they are the key drivers of wound inflammation and their resolution. Macrophages actually have a receptor-mediated pathway described in 2013 in a major journal called the Journal, in this case there's a pathway in oncoimmunology, where they actually take up collagen fragments into them. So why do they now eat these collagen fragments up? We don't know, but if you look at other studies that have been published, they actually show that these collagen fragments could have varying levels of influence on the fate of the inflammatory system. Taken together, they make a very compelling case that once you actually end up starting making these fragments, they are not silent entities to be forgotten. As you saw part of the data in the previous talk, and I'd like to make the same story in two different ways. So what are the two different ways? In one case, I would argue that when you put a collagen-based dressing, not a collagenase, a collagen-based dressing on the wound tissue will have collagenase in it that would now act on the intact collagen, not on the half-broken collagen in a chronic wound that has been tampered with and degraded, partially degraded. Fresh collagen acted upon by collagenase. And this reaction will result in collagen fragments which actually are expected during acute wound. Because now you have acted collagen, intact collagen being acted upon by collagenase of the wound. That's one scenario. The other scenario is where you actually go in with collagenase. You don't go in with collagen dressing, and the collagenase will act upon not only collagen of inside the wound, but also on the skin outside, and would actually start breaking down collagen, intact collagen, around the wound as well as within the wound. And in the process, you would end up generating also these acute collagen fragments. In both cases, you have a very interesting buildup of these fragments, which then influence macrophage function. Now, coming back to the slide, what you see here is that just by the addition of collagen-based dressing, you can not only build the accumulation or recruitment of macrophages to the wound site. So for those of you who are still struggling to understand whether macrophage is a good thing or a bad thing, in a quick sentence, you simply require macrophage. You have to have macrophages coming to the wound site, but then they will all have to be turned off in a reasonable time frame. So I don't think inflammation inherently is a bad thing. It's absolutely required for the healing process, except that there needs to be a timely resolution. So to that end, recruitment, acute phase recruitment of macrophage to the wound site is a good thing. But then quickly, if things are all going all right, the macrophages need to be switching from a M1, or the pro-inflammatory state, to the M2, or the reparative, or the anti-inflammatory state. So what you see here is not only the recruitment of macrophages as shown here in the macroscopic image, but also you see in ARG1, CCR2, MRC1, these are all markers of M2, or the reparative phenotype. So that not only are they coming, but they, in a timely manner, are then getting moved over to the reparative format. They're not stuck in the M1 format. So this is a quick data from the collagen-based dressing. Now, we have published a number of papers with collagen-based dressings, and clearly there is a general, consistent observation that if the conditions are right, and that's a very critical piece, that you do see collagen-based dressings actually ending up releasing these peptides, which then, if you will, tickle the macrophages in the right way so that they move over from an enraged format to a more reparative or a friendly format. And there's a lot of interesting papers speculating as to how collagen-based dressings or collagenases may influence the wound inflammation, but there is actually in the literature no traction of how this is accomplished. And I'll now share with you some data on that. So the rest of the talk would focus on Clostridial collagenase ointment, about which you have just heard. In this case, we have been using Santal, and it is commonly, as you know, available in the market. Now, as we get into the data with that, there is a very important thing to note, and this you would all be very familiar with, that within a wound site, you have a whole bunch of healthy cells, but then you have a lot of dead cells. Now, as surgeons or clinicians, one is interested in debriding the wound with a number of ways. As you saw, there was a chart, and you could do it with a knife, you could do it in one of many other ways. But the point being, you are debulking the wound of not only infectious agents, but also dead tissue. Now, that's at the macro level. At the micro level, you have a lot of dead and dying cells, and it is these macrophages that do come to the wound site, and their job is to eat away the dead and dying cells. And that process is called efferocytosis. This is not something that you can really regulate, because that process of dying at the cellular level is a continuous process and you're not going after every single cell with your knife and taking it out. So there is a physiological process for that, and that is acted upon by the macrophages. Now, under diabetic conditions, our group has published, and there's another paper coming out now in the Journal of Immunology, the ability of a macrophage to recognize, so first they recognize, and there's a bridging molecule called MFGE8. So they recognize, and after the recognition, they engulf. So it's essentially, broadly speaking, a two-step process, recognition and engulfment. And what we reported is this bridging molecule, MFGE8, can get glycated or sugar-coated. So under conditions of diabetes, when this recognition molecule is glycated or sugar-coated, the macrophage is here, the dead cell is here, but they can't find each other. And this macrophage is angry because it is supposed to be eating about a dozen dead cells before it turns over to an M2. Okay? So that's a trigger. Efferocytosis and a full belly is a trigger to be moving on to a more reparative format. So here what you see is that a buildup of dead cells, as you will see in diabetic mice, and this has been also shown in this paper in humans with diabetic ulcers, that there will also be concomitant buildup of pro-inflammatory cytokines like TNF-alpha, IL-6, so on and so forth. Now, a very interesting part of this is as efferocytosis happens successfully, if it doesn't happen successfully, the macrophage is stuck. It is there, and it is constantly spitting out pro-inflammatory cytokines like you saw in the previous slide. There's a pathway for that. For those of you who are interested in the science of that, that pathway is mainly orchestrated by a microRNA called microRNA-21. I will not get into the details of this and keep sticking to the broader aspect of the story here. And the paper that now is coming out in the Journal of Immunology shortly demonstrates how de-sugar-coating this protein actually helps move the chronic inflammation into a more resolution phase. Now, finally, to come to these summary slides, so there are a number of mechanisms by which M1 and M2 will move. There was a time when people thought that M1 macrophages and M2 macrophages were two different sets of macrophages. And that got now debunked. We now know that the same set of macrophages that come into the wound site can experience certain microenvironmental factors which will make the same macrophage switch over to being an M2. So it's not like those M1 will have to disappear into thin air and then the M2s come. Not true. So M1s will participate, as one example, in successful efferocytosis, and literally each M1 will ingest successfully up to a dozen or so dead cells, and at that point a molecular switch within the M1 will be triggered. Following that, they will now move into. Now that's one condition, and there are many other conditions such as the exposure to very specific collagen peptides, small molecular weight peptides, that can also make that transition from M1 to M2. So to summarize, what you have here is that enzymatic debridement can serve multiple functions. It is not really akin to what you have with a knife debridement, period. Indeed, it does remove bioburden, including surface-adherent biofilm infection, like I said. It processes skin ECM to generate collagen fragments, and this is not something that you may have in some other forms of debridement. And the derivative collagen fragments support the resolution of inflammation. So what you have in general is that enzymatic debridement on its own can directly debulk biofilm. It can directly, through collagen fragments, subdue inflammation and switch it over to a more M2 fate. But then again, debulking the biofilm itself will take away those pro-inflammatory pathways, as a result of which that would also favor the resolution of inflammation. With that, I think I'd like to thank our institution, Greetings from Ohio State, and all the different sponsors of the wound healing work going on in the laboratory. And I would now like to invite Jeffrey Lerman and Dot Weir. First, Dot Weir and from Orlando, and then Jeffrey from Pennsylvania, Springfield, Pennsylvania. Dot. Yeah.
Thank you. The most enthusiasm I've ever heard about macrophages. That was great. So most of us in this room are clinicians. How do we take that information and translate it over into something that makes sense to us? And the work is not done. This is still early work that's going to make more sense to us as we all learn it and understand it more. So when we're out in the clinic and we're looking at, and in the hospitals and in our care areas, we're looking at these wounds and we stand over them and we see what we see, and it's our decision as to how do we move this wound forward and then take some of the things that we learn at conferences like this and make it make sense. We can look at a wound like that and say, it looks okay. There's definitely some debris there. It needs some more work, but we're starting to see some granulation tissue. But the wound appearance really can't, as we've just heard, tell us what's going on down at the microbial, the biochemical, or the cellular standpoint. And so the presence of microscopic debris is really what this is all about. And so when we look at that wound, Dr. Robert Weimer, who's a podiatrist in the Philadelphia area, he did a biopsy of this wound. And he went back to the lab and he looked at did an H&E stain on it. And what you're looking at in this inset is the result of that stain. And all the little blue dots and things that you see are inflammatory cells. So we can see that this wound is still stuck in this chronically inflamed state. But the other things that he saw coagulative tissue necrosis, which is Dr. Sen was just talking about. You have these cells that go through apoptosis, or this programmed cell death. But if their structures are not cleared out adequately, they're left behind, again, further igniting that inflammatory response. Also, cicatrical fibrosis, some changes that look more similar to scar tissue. So the wound that we're looking at that looks pretty good probably isn't. And we need to have something that can help us to move it along. And that's where collagenase may fit in.
We've gotten a good picture of what's going on a microscopic level with the Clostridial collagenase. And using that as a background, we can now shift to see what it looks like on a clinical level, starting with a cartoon depiction, which we'll look at here, and then we'll show you some real case studies. Starting with what most of us see every day, are brown, non-viable, nasty tissue sitting in the wound bed that we don't like to see. And it's sitting in the base of the wound, as is pictured here, and it's being anchored there. It's being held there by the strands of collagen that we've heard so much about. So what we want to do is cleave those strands of collagen, releasing their hold on that non-viable tissue. We start with this, with the non-viable tissue with the wound bed, and then introduce the collagenase that we've been talking about, allowing it to seep down to the wound bed with the enzyme collagenase, cleaving the strands of collagen, releasing their hold on that non-viable tissue, so that we can then very easily debride away or wipe away that non-viable tissue. And in doing so, that helps to promote the granulation tissue that we want to see. And that helps us achieve the wound bed preparation that we talked about earlier this morning, if you were here, and get us moving in the direction of healing that we want to move in. And now Dot and I are going to go through some actual case studies on patients that we've treated.
So as we look at approaching the patient and using a drug to help us clean up these wounds, there's a couple of important points I want to make about the use of Clostridial collagenase. And one is that if it's not used appropriately, it's not used properly, it's not going to work as well in our hands. So we want a couple things. We have to make sure that it's moist. Moisture is going to activate the enzyme. So if we cover it with a dry dressing and there's not adequate ambient moisture in the wound, it's simply not going to work as rapidly. We want to also make sure we're dosing it appropriately, putting enough of it onto the wound, covering it the entire surface, a couple of millimeters thick, so that it has adequate amount to penetrate and do what Jeff just said it would do. Then we want to make sure that we change it every day and that we create the environment that's going to make it work as well as it possibly can. So let's look at a few cases. This was a lady who was in a long-term care facility in the Kissimmee area, and my medical director was in this facility and wanted to try to do some sharp debridement on her. So she has dementia, she was combative, they tried to turn her over, and she didn't want anything to do with that. And so she became combative, and of course, anytime you're holding a sharp instrument and somebody's flailing, somebody's going to get hurt. So they stopped it, and he said, well, let's bring her into the clinic, and we have this ultrasonic debriding device, which is wonderful, and we'll use that on her. Well, I don't know, this was her first visit with us, so I don't know why we thought that she was going to like that anymore, but she didn't. So we sent her back, and we try not to bring these folks from long-term care in any more frequently than we have to, because they miss meals, they get more confused. And so we sent her back and said, let's get her something to keep her calm. And at the same time, we ordered the collagenase to be started, covered with a moist gauze daily, and to be returned this time in 1 week. So they had used it every single day. We were able to do a little bit of the ultrasonic debridement, and this was the end of the first week. And so one of the important things also in using this drug is that we want to make sure we're doing effective cleaning in between each dressing change. More than just sprinkling and squirting a little bit of normal saline on it. A good cleanser, we have an ultrasound. This is after ultrasound. That's ideal. But we have the monofilament pads. We have close pulse irrigation. Some way that we get a little velocity because we've got a drug that's liquefying necrotic tissue. We want to get it as clean as we possibly can. So sent her back, had her come back in 3 weeks, and we've got obviously a cleaner wound bed. Her orientation is different. Her feet were down here this time, and of course she's flipped over this time. We have a little deeper area that's starting to declare, but we're much cleaner, seeing some epithelial migration. 3 weeks later, they're continuing to do it daily. It's bridged already. We still have that little deeper area. And then at 8 weeks, we're completely clean, have a nice established granulating base, and we can go on to another product. And in this case, we just went on to a collagen product. But that's in 8 weeks, so we were very happy with that. This is a gentleman who got a gift from the hospital. He was in for a FemPop bypass, had some complications. He had diabetes for many, many years, and he developed a pressure ulcer in-house. And so this was his initial visit to our clinic. He is now ambulatory, but has a densely necrotic wound, unstageable pressure ulcer. He lives with his wife, who is able to do all of his care. We used that same ultrasound debriding device that we have and taught her how to begin the collagenase, cover it with an oil emulsion dressing, an adaptic type dressing, and a dry secondary dressing, and to change it every single day. This is at day 10. We did a little bit more of the ultrasound debridement. The tissue is healthier, but still not completely healthy. Still some slough present, so we're going to continue the same treatment plan. On day 24, mostly clean, healthy tissue. At this point, he's got some hypergranulation tissue, which we normally would have gone after with our ultrasound. I can't tell you at this point in time why we did not. But we continued the collagenase, but added a pigmented PVA foam that we use, and in our hands, it does a really nice job of reducing hypergranulation tissue. So then this is the next visit at day 35. The collagenase, it was now clean in our eyes. We discontinued that, started the continued the PVA foam for a week. Then she switched to a hydrofiber and a bordered foam. And then at day 49, it was down to this point. So again, very successful results, making sure that we get it nice and clean to get it onto a more healing trajectory.
2 case studies for me, and then we've left some time for question and answer. First case study of mine, a guy I took care of. This is Diabetic Foot Ulcer. And what we're looking at here, this is his right hallux. So on your left, that's his right big toe, smushed up against his right second toe. So this is proximal, lateral, right hallux in the first interspace area. 55-year-old uncontrolled diabetic. His A1C was 12 point something. Smoked cigarettes. And his story is he comes every 2 months to the podiatrist for his at-risk foot exam. We check pedal pulses, do monofilament, toenails, calluses, stuff like that. And as is often the case with these diabetic foot people, he had no idea that that ulcer was there. Just came in for his at-risk exam, pedal pulses, and then we looked between the toes, and when I spread his right hallux and right second toe apart, that monster was sitting there. Upon questioning him, what happened? Did you wear different shoes? What's the story? We had had a snowstorm in Philadelphia the week before, and he thought it was great that he had done his driveway and his neighbor's driveway. So I think what happened is it was macerated and sweaty in that boot, and with his, did I mention he smokes? With his neuropathic cigarette skin, that hallux rubbed up against his second toe, and that thing opened up. So I was worried about this. You can see that cigarette skin, right? Thin, red, shiny, no hair. I was worried about this guy. So this wound is not ready for healing. This needs wound bed preparation, which is what we've been discussing, the importance of using enzymatic debridement with Clostridial collagenase to help us achieve excellent wound bed preparation. So at this first visit, I did not do a sharp debridement. I was worried about where that was, small vessel disease, can't really tell how deep it is. There could be neurovascular stuff going through there. So at this first visit, no sharp debridement, just enzymatic debridement with Clostridial collagenase. He did that for 2 weeks, and when he came back, it looked a little better, right? We've gotten rid of a lot of that yellow-brown stuff. We start to see some healthy granulation there. It's a little smaller. This time I did do a sharp debridement, still not too aggressive, but scraped it up a little, got it bleeding, had him continue with his Clostridial collagenase, and had him come back 2 weeks later. Please remember the cartoon picture that we looked at a couple minutes ago with the concept of the collagenase cleaving those strands of collagen. So he went 2 more weeks with his collagenase, and when he came back, at first glance, it looks like we may have gone backwards. This doesn't look so good, right? But what's going on here is this was just a very thin oval of non-viable tissue that I very easily scraped away. I just scraped it with a scalpel. You could have done it with a fingernail or a wet piece of gauze, and that oval lifted off in one nice piece. The collagenase had cleaved those strands of collagen, and about 60 seconds after this picture was taken, this picture was taken. That's what was sitting underneath that little oval of non-viable tissue. So the collagenase, again, we saw it at a microscopic level earlier. Now we're looking at on a clinical level. The enzyme had cleaved those strands of collagen, allowing us to very easily wipe that away. And now we've achieved wound bed preparation. This is ready to heal. I immediately switched him to Bicaplermin and introduced the very powerful platelet-derived growth factor that offers, and he went on to heal quickly. And thank goodness he has remained healed. He still comes every 2 months, still got his pack of cigarettes in his shirt pocket, but he's okay for now. One more case study. Diabetic guy had a heel blister, posterior heel with that fluid-filled blister that pops. How often have we seen this? As soon as it pops, fluid comes out, deroofs. This is what it looks like, and we do our best to keep it hydrated, try to get him offloaded, what this guy is totally incapable of. And despite our best efforts, 2 weeks later, we have this mess. This needs wound bed preparation. Not ready for healing, not ready for a graft, not ready for platelet-derived growth factor. And really can't too aggressively, sharply debride this, because with these, we'll just keep digging and digging and digging, and there's just more yellow, sub-Q, avascular, fatty stuff down there. So little bit of sharp debridement here, but not too much. For the most part here, we're going to rely on the enzymatic debridement, again, to cleave those strands of collagen. So he was started on Clostridial collagenase. After 2 weeks of that, we see we've gotten rid of a lot of that black necrotic stuff. Not done yet. Still more work to do here. Continued with, and I did sharp debride this, but you don't get that much off. It's that yellow fatty stuff that comes off, and you have to be careful how deeply you dig here. So he continued with the collagenase. He went another 3 weeks. Now we're starting to see it get smaller. That peri-wound callus needs to go away, so we shave that off. Can be a little more aggressive now with the debridement of our wound bed as we see more granulation tissue. Continued with the collagenase, and at this point, I thought wound bed preparation had been achieved. We've established some healthy granulation tissue, also switched him over to that platelet-derived growth factor, and he did go on to fully heal, with those pictures being taken every 2 weeks there, with a really nice result. He also, thankfully, has remained healed. Thank you so much for your attention. We have some microphones here for question and answer, and really, a varied expertise on the panel, and we'd love to take some of your questions, please.
Thanks so much for all of your excellent presentation. Really, it's very fantastic presentation and lectures as well. My question to you, sir, do you think that the antibiotic usage for such scenarios that you gonna mention, is it beneficial apart from using your technology, or is it's fair enough? The second question, did you do a culture and sensitivity test as well for that one?
So the question was, what about using antimicrobial therapy in conjunction with the enzymatic debridement? And then the second question was, did I culture either of those? Antimicrobial therapy, I think, should be reserved for the presence of infection. And we have to be very careful with the overutilization of antimicrobial therapies. We know we have an emerging resistance problem to antibiotics in our country. So we have to be careful with that. And I would not advise prescribing antimicrobial therapy unless we've confirmed the presence of infection. Redness, heat, odor, drainage, pain out of proportion, stuff like that. And to answer the question in these two scenarios, I did not do a culture I don't culture unless there is clinical evidence of bacteria, and we have to be careful about these superficial culturette swabs potentially leading us down a road we don't want to be on. And really, if we suspect infection, ideally should be deep tissue culture under sterile conditions.
Thank you as well. We run into a cost factor. Any suggestions, or is there any help getting this product when the cost from a patient with private insurance, in my state anyway, can be $200 and $300?
Question was concern over cost. Couple thoughts on that. The first is, be sure you are prescribing it the best way possible. The manufacturer has a specialty pharmacy prescribing option in most portions of the country, where you're not just sending them to the corner drugstore. And this option helps to ensure you get it covered. They even offer copay assistance and delivery of the product to the patient. So look into your options as far as how to prescribe that, and I can give you more details when we're done if you want. And one more thing about cost, and if you were in the room this morning, forgive me for repeating myself, really fascinating study that was led by Dr. Kersner, one of our co-chairs along with Dot here. Study showed that when you use advanced treatment options early in the wound healing schedule, it can actually decrease the overall cost of care for the wound. So using a more advanced treatment early, what may be a more expensive treatment early, can actually decrease the overall cost of care, because in many cases you're going to shorten the duration of care, and if you prevent one disaster, right, there's tremendous cost associated. A diabetic foot admission is $80,000. And if it comes down to your patient's cost, we're weighing that against some of the awful statistics that we covered this morning with 5-year mortality rate, and 49% of these never heal, and really weighing it against the cost of losing a limb, which is tremendous.
Primarily for Dr. Sen, but anyone can jump in. When you were speaking about the pro and anti-inflammatory properties of collagen, I was curious, does it matter after the wound bed is clean what type of collagen you apply to a wound?
So that's a very important question. I think right now, that's the reason we do also those collagen dressing studies, because there you can control the type of collagen that you're producing, providing, because once you have collagenase, it's going to actively function on all the collagens that you have on the skin. So right now what we know, we don't have the answer to your question, but right now what we know, that collagen 1 is very active. We also have seen some function with collagen 3, but a systematic study of exactly which collagen would produce these fragments. Oh yeah, the other cue we have is that these are not long-chain peptides. These are very short-chain peptides. So that would lead to the notion that this could not be very collagen-specific, that you could have this from a number of collagen. Maybe Ira would have something more to add.
Yeah, so to follow on that, it turns out, per your question, that different domains in the fibrillar and non-fibrillar regions of the basement membrane, as well as the interstitial, the type 1 collagens, both the basement membrane as well as the interstitial collagens are cleaved in ways that give rise to peptides that actually stimulate the different population of cells, both within the connective tissue as well as the overlying epithelium. So it's absolutely essential. Your point is a good one. And clearly the enzyme being promiscuous, Clostridial collagenase being somewhat promiscuous in its cleavage behavior, can actually not only cleave the parent collagens, whether interstitial or basement membrane, but in addition the collagen-associated proteins. You might have noticed in that chart that I showed so quickly that there were both collagen-containing peptides as well as collagen-binding fragments from molecules that associate with collagens. And all of that informationally is really strategic with respect to the way in which the cells in the different compartments, epidermal or dermal, respond to the injury responses.
In regards to the normal epidermis surrounding a wound, particularly in the interdigital area that you demonstrated, how are we preventing the healthy epidermis from not getting the Clostridial collagenase effect of the enzymatic debridement, particularly if the patient's trying to self-apply a dressing in the web space?
The question was, how do we avoid the collagenase harming the healthy tissue? So the important point about the Clostridial collagenase that we're talking about, and I'm taking a big risk saying this in front of the smart guys, correct me if I say something wrong. The Clostridial collagenase that we're using debrides selectively. It's different from our own endogenous collagenase. Is that right?
It's partially true.
Partially true. Let me just run with it then. The Clostridial collagenase what we're talking about debrides selectively. Healthy collagen is protected by a mucopolysaccharide sheath, which Clostridial collagenase cannot penetrate. So we want to keep it in the wound bed, but in that guy, if it milks over the side a bit, I'm not worried about it eating away at healthy tissue because it debrides selectively.
What I would add to that is sometimes I think we see patients react to their drainage. If we see denuded tissue, skin, intact skin, or irritation around, we will almost always, especially if we're expecting a lot of drainage because we have a lot of necrotic tissue, put a barrier around it to protect that peri-wound skin, because we're going to create more drainage, usually, but as we liquefy the necrotic tissue, so protecting, it probably needs a little extra protection, not from the collagenase so much as from the patient's own exudate.
I also just want to remind everyone that indeed the collagenase is helping to debulk the necrotic tissue, but at the same time the enzyme is activating the cells that are bordering the necrotic zone. In fact, we all know that healing results from the immigration of the wound margin, the cells that are adjacent to what might be necrotic. And in fact, we know as well that the enzyme remodels the matrix upon which the cells rest, giving rise to these peptides that not only interconvert macrophages, but stimulate the migratory and proliferative responses to injury that are so essential for healing. So I think that it's likely to be right for the wrong reason, essentially, that indeed the enzymatic debriding agent is debulking the wound, but in fact it's activating the cellular responses to injury by activating the promotion and production of these peptides.
Hi, thank you. Really appreciate the information on collagenase. Lots of stuff I didn't know. After the staging and then the wound is in a good granulation phase and it looks like it's headed towards healing, you may have shown it, I don't think I saw it, but comparing use of the collagenase with other dressings that would support the wound, in your mind, is there anything that you can share that would say, hey, this is, you're getting advantage of a week, 2 weeks, whatever, compared to other dressings?
You're talking about secondary dressings over the collagenase?
No, if I were not to continue using it, say for a cost reason or something, I would go to another, dressing compared to that.
I think then you're still going to make your decision based on the assessment of the wound. You're going to use something that either addresses moisture, either absorption or donating moisture, depending on how far you're able to get the wound in the cleaning processes and in the debriding process. If you had to stop the collagenase early, is that what you're sort of referring to?
So the question is, how do you know when to stop? Right? When do you switch? So package insert for this says to use it until healthy granulation tissue has been established. And really, in my mind, I translate that to mean when wound bed preparation is complete. So when we see some granulation buds, that's what I tried to demonstrate in these two examples, showing you not only when I used it, but when I stopped. So again, package insert is to use it until healthy granulation tissue has been established, when it's mostly clean, red, and granular, when it looks like it's ready to shift from wound bed prep to wound healing. That's when I would discontinue the use of the collagenase and switch over to something else that has more of a healing indication. Thank you so much for your attention, guys. Enjoy the rest of the day.